Okay, so here we go. We're already at chapter 6, which is the TMJ, or temporomandibular joint. And like most chapters, we will start off talking about the muscle actions. And in particular, you're going to notice that there are not any primary movers on here. Everything for TMJ is going to be secondary movers, which is a little interesting, a little different. So if you look at opening and closing the jaw or the mouth, there's going to be your secondary movers, which are the only ones that move. So if we're closing the mouth, we're looking at temporalis, masseter, which is a key one, and medial pterygoid. And for opening the mouth, we're really only looking at lateral pterygoid. There's other ones here. You can see the ohyoids bones, muscles basically, and those ones don't contribute as much. They're really, even though it's not listed here, they're considered more tertiary muscle contributors at these areas. The other thing I do just want to draw attention to is this is sagittal plane here for opening and closing your mouth. It's also sagittal plane for protrusion or retraction. Protrusion is taking your lower mandible and sticking it out, away from your head, and retraction is pulling it back in. And what's interesting about that is it's a translation effect, and this is a rotation. But ultimately, these are both sagittal plane movements, and even opening and closing the mouth, those are going to contain a certain amount of translation built into them, especially the second phase or the second half of opening the mouth. It contains a lot of translation, and this will make a little more sense once we start to look at a video of this and how this looks. So here we go, the joint that we're focusing on. Just a summary here. It is the only glenoideo-myarthrodial joint, but ultimately it's a synovial joint. So with any synovial joint, that means there's innervation, that means there's a synovial joint capsule, it could develop capsulitis. So just like other joints apply, synovial joints have those same things. So it is a synovial joint that's innervated, and it's lubricated with the synovial fluid as well. And in this one in particular, it's interesting because there's a disc in there. Very important surface. The TMJ joints, just as an FYI, they obviously have a lot of repetitive stress and load, and they can take 600 to 1200 newtons. And if you convert that, that's several hundred pounds of biting force that our jaws can do. So just kind of interesting. What are the articular surfaces that make up the TMJ? So you have the temporal bone, which is why the temporalis muscle is involved with moving the jaw, and that fits nicely with the mandibular condyles on each side. So let's take a look at that a little bit closer. So here you go. There's the mandibular condyle, there and there. The ramus is the part connecting to that. Then obviously you have this angle, base of the mandible, and there's the coronoid process here as well. So with this, there's the proximal and distal part, and obviously the temporal bone is that stationary part. So with this, there is that disc. I was starting to talk a little bit about that disc that's in there. It's kind of a unique shaped disc. It's not like an intervertebral disc, like a circle or a hockey puck that we think of it. It has this biconcave aspect to it, and it deforms a lot more than other discs within our body. So with this, the shape increases conformity, and it helps to allow for that mandibular condyle to move. It'll make a little more sense when we look at a video of this. But it is a synovial joint, so here's your joint capsule within that area, and it's highly vascularized and innervated. So for that reason, there can be a lot of pain associated with the TMJ if there's some type of dysfunction, and we'll typically call that a TMD for temporomandibular dysfunction. Sometimes even in documentation you'll see TMJ/TMD. But this is a highly innervated joint. Okay, so here a summary of some of the ligaments, temporomandibular ligament. This is going to be connected to the lateral portion of the capsule. You have the stylomandibular ligament. We're not going to focus too much on that one. That's a weaker one, but it does limit protrusion. And then you have your sphenomandibular ligament. Now, this is a strong ligament that helps to keep that suspended. And it prevents excessive anterior translation. That's going to occur with opening of the jaw. So when the jaw is very wide open, to make sure that you don't over open, for lack of a better term, your mouth. So we talked a little bit more about that capsule. And so you could see with this capsule, like anything, there would be a capsular pattern. And this is something you really probably don't have to think about too much or even memorize. If someone had a capsulitis of the TMJ, what do you think they would be limited with doing? Do you think closing their mouth would be more difficult, or opening their mouth would be more difficult? So there you go. So I typed the answer. Just so you have it there. Opening is more difficult or more limited than closing the jaw, and that makes sense. And even if you think about someone with a jaw fracture, an injury, they may have their jaw locked or basically secured in a relatively closing position. They may be able to get a straw between their teeth, but they're in that position. And then when they recover from that fracture or that injury, they have trouble with opening, end range opening. So with our jaws, and if you think about what we are positioned most of the day, most of the time our jaws are closed. And so functionally, we don't get to end range opening very often. So with the capsulitis, we have a loss of opening of the jaw. Okay, so some accessory joint structures with this. When we talk about muscles of mastication, what is mastication? That's chewing. Here's a little bit of a visual for some of that. The disc is attached to the joint capsule. And the disc is also attached to the tendon of the lateral pterygoid muscle. So with that, there's a connection there. And then posteriorly, the disc is attached to a complex structure, and that's the bilaminar retrodiscal pad. The real thing to mention there is it's vascular and nociceptive. So when you see the term nociceptive, you're thinking about a pain-generating source. So once again, I've highlighted this before. The TMJ can be highly innervated, and with any disruption here, it can be quite painful, and there can also be referral of symptoms into the temporal region, cervicogenic headaches. A lot of things can be involved with that. And then medial and laterally attached to the joint capsule as well. So this is a very important area to go after. So for the next part, let's look at a little bit of emotion here. As I'm going to play a little video with opening and closing, and I want you to look for this curvy linear motion. Just like at the knee, there is a curvy linear motion to the axis of rotation. At the TMJ, it's significantly more pronounced. And what's interesting is it changes early into the motion, early phase, it's not that much, but then to the second phase, late opening, or really the second half of opening, you'll see there's quite a bit of this anterior translation or anterior gliding, if you want to look at it that way. So let me get this video ready.
The TMJ is responsible for jaw movement and is the most used joint in the body. The TMJ is essentially the articulation between the condyle of the mandible and the mandibular fossa, a socket in the temporal bone. The unique feature of the TMJ is the articular disc, a flexible and elastic cartilage that serves as a cushion between the two bone surfaces. The disc lacks nerve endings and blood vessels in its center, and therefore is insensitive to pain. Anterolateral pterygoid muscle, a muscle of chewing. Posteriorly, it continues as retrodiscal tissue, fully supplied with blood vessels and nerves. The mandible is the only bone that moves when the mouth opens. The first 20 millimeters opening involves only a rotational movement of the condyle within the socket.
We'll call this
For the
first
mouth
20
to open
millimeters
wider,
early
the
phase.
condyle and the disc have to move out of the socket, forward and down the articular eminence, a convex bone surface located anteriorly to the socket. This movement is called translation. The most common disorder of the TMJ is disc displacement, and in most of the cases, the disc is dislocated anteriorly. As the disc moves forward, the retrodiscal tissue is pulled in between the two bones. This can be very painful as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc forms an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back ends of the disc and onto its center. This produces a clicking or popping sound. Upon closing, the condyle slides back out of the disc, hence another click or pop. This condition is called disc displacement with reduction. Disc dislocation. The condyle stays behind the disc all the time, unable to get back onto the disc. The clicking sound disappears, but mouth opening is limited. This is usually the most symptomatic stage. The jaw is said to be locked as it is unable to open wide. At this stage, the condition is called disc displacement without reduction.
Sometimes you'll hear this called
Fortunately,
lockjaw.
in majority of the cases, the condition resolves by itself after some time. This is thanks to a process called natural adaptation of the retrodiscal tissue, which after a while becomes scar tissue and can functionally replace the disc. In fact, it becomes so similar to the disc that it is called a pseudodisc.
So for that video, just a good overview of the mechanics. In the next video, we'll talk a little bit about the muscles involved, and we will go into further detail. You're probably wondering about the convex, concave, and the arthrokinematics of this joint. So we'll get into that in the next video. Thanks.